With me today is Jim Moore, a GP with a special interest in cardiology who is well known to many of you. Jim and I, together with cardiology consultant colleagues, have put together some guidelines on the diagnosis and management of atrial fibrillation, which are available on GCare. This podcast aims to provide a short overview of some of the key points covered in the guidelines. Thank you for joining me today, Jim. AF is something that we as GPs commonly see in general practice. We are sometimes unclear as to when to refer new presentations to secondary care. Could you give us some advice on this?
Thank you, Sheena. The vast majority of people presenting with atrial fibrillation can be both diagnosed and managed within primary care without referral to the accident and emergency department, and indeed without referral to secondary care. I think it's important to emphasise that patients presenting with an irregular pulse may have other reasons for this. So, in patients with atrial fibrillation, one needs to undertake some form of ECG assessment to make the diagnosis. This can be done in two different ways. Traditionally, we would undertake a 12-lead ECG on patients, although we're aware that this may not be readily available when patients present in primary care. Many of you will be aware that there are now lead 1 devices such as a live core, or more recently called Cardia devices, which can be used to provide a much quicker diagnosis in primary care, and then at a later date a 12-lead ECG may be undertaken. Atrial fibrillation is the commonest sustained arrhythmia that we see in clinical practice, and patients present in a variety of different ways, sometimes with symptoms such as breathlessness or indeed palpitations, or they may be asymptomatic and just picked up at a form of routine cardiovascular check, perhaps in a long-term condition clinic. It's very important that we make the diagnosis by undertaking an ECG.
So who are the patients that we should be referring to the emergency department?
So, by and large, there are a number of symptoms and clinical findings that would indicate that a patient needs to be more urgently assessed in a local emergency department. Patients presenting with chest pain or acute breathlessness, which of course may reflect some form of underlying cardiac decompensation or heart failure. Patients where there is a history of syncope, where they have lost consciousness. Patients with particular clinical signs such as a fast heart rate, which is particularly in excess of 150 beats per minute, or patients with a low blood pressure where the systolic is less than 100, they should all be referred for acute assessment.
My experience is that most people do not meet these criteria for emergency admission. So would you be able to talk us through the initial management of these patients in primary care? For example, do we prioritise rate control or anticoagulation, or do we try to address both at that initial presentation?
This is all very relevant to the first consultation. Both the areas that you mention are important to address at that first meeting. The national guidance would suggest that in patients that are not hemodynamically compromised, then we should firstly concentrate on the stroke risk in this group by undertaking some form of risk assessment.
Is this also the case for patients with paroxysmal AF or atrial flutter?
Indeed, in patients with paroxysmal AF, whether it be very infrequent or not, and in patients with atrial flutter, we would still use the same form of risk assessment for stroke.
So could you remind us at what level of CHA2DS2-VASc score would we initiate anticoagulation, and also where the Hasbled score comes into this decision?
Patients with a CHA2DS2-VASc score of 2 are deemed to be at high risk and should be offered anticoagulation. Patients with a CHA2DS2-VASc score of 1 are at intermediate risk of stroke and should be considered for anticoagulation, whereby the risks and benefits should be discussed with the patient. Patients with a CHA2DS2-VASc score of 0 are truly at low risk and should not be considered for anticoagulation. We should, of course, assess bleeding risk in all patients, and this is done using the HAS-BLED score. The HAS-BLED score should be used to identify modifiable risk factors for bleeding, but it should not be used as a reason to deny a patient anticoagulation.
In patients who need anticoagulation, how do we decide between using warfarin or a DOAC? And if we decide on a DOAC, is one more effective or preferable to another? NICE
currently recommend that you can use either warfarin or a DOAC to anticoagulate patients for the prevention of stroke. In terms of choice of DOAC, each of the 4 DOACs have been shown to be as effective as warfarin in reducing stroke. And for me, what is important is the simplicity both of prescribing these drugs and indeed how easy any of these individual drugs are for patients to use, and this should drive our choice of DOAC. What's important is the dose of the DOAC, and we should follow current guidelines regarding this. In particular, when calculating the renal function, we should use estimated creatinine clearance and not EGFR. Given the short half-life of DOACs, it is important that these drugs are taken regularly, and it's also important that for individual drugs, where there are particular recommendations, these should be followed. For instance, rivaroxaban should always be taken with food.
Thanks, Jim. It's probably worth mentioning that we do also have on GCare a DOAC prescribing guidance for clinicians and also a leaflet for patients to encourage compliance. So, having assessed their stroke risk, what medication should we be prescribing for rate and symptom control?
Firstly, Sheena, I would refer listeners to the AF GCare pathway, which I think gives an excellent overview of how we should manage heart rate in this particular patient population. In patients whose heart rate is in excess of 100 beats per minute, up to 150 beats per minute, I would suggest considering using rate-limiting drugs, and first line would be using beta blockers. Where patients are intolerant of beta blockers or have contraindications to their use, I would recommend the use of a rate-limiting calcium channel blocker, and usually diltiazem would be the drug of choice in this group. Where using either a beta blocker or a rate-limiting calcium channel blocker, and where the heart rate is still not controlled, I would consider adding digoxin. And then, if the heart rate remains uncontrolled, then I would refer the patient to cardiology. In patients whose heart rate is less than 100 beats per minute, but who are symptomatic, for instance, they may be breathless on exertion or have palpitations, then again, I would consider using a beta blocker as first-line therapy. We do, at times, albeit rarely, use the combination of beta blockers and rate-limiting calcium channel blockers together, but you must be very cautious, as this combination can, in some patients, precipitate heart failure.
Which patient should we be referring to secondary care for cardioversion or atrial ablation?
So again, Sheena, the detailed guidance on this is contained within the GCare AF pathway. But as a rule of thumb, initially, looking at cardioversion, patients who are admitted acutely may be considered for cardioversion depending on the length of time they've been in atrial fibrillation, and in particular, if this is known. For patients who have been seen routinely through cardiology, cardioversion is often used as a means of assessing whether their AF-related symptoms, again typically breathlessness or palpitations, will improve when they are converted back to sinus rhythm. And in patients who do get benefit from this sort of intervention, they may in the longer term be considered for left atrial ablation therapy.
Thank you, Jim, for that taster around atrial fibrillation management. I appreciate it is a lot of information to cover. Therefore, the Circulatory CPG are keen to work with PCNs and localities to deliver a CVD education event sharing the latest guidance and patient case studies.